Good afternoon. Welcome to this state-of-the-art session targeting mutant ER. It's my pleasure to introduce Dr. Geoff Greene from University of Chicago, who will be reviewing SERMs versus SERDs for targeting ESR1 mutations.
Let's just check this out. Thank you. These are my disclosures. So what I'd like to do in my 35 minutes, not 20 minutes, is to give you a feel for the field of SERMs and SERDs, and also ones that have dual properties. It covers a wide range, as you'll see. And then kind of leave you with some questions at the end about where we should be going next, actually. So what I'm showing you on this slide are classic molecules that we know that bind the estrogen receptor, 4-hydroxytamoxifen, the active metabolite of tamoxifen, raloxifene, fulvestrant, the so-called complete estrogen antagonist, and then beta-doxifene, which has mixed behavior. It's both a SERM, a selective estrogen receptor modulator, and a degrader. It has both properties. What I want you to notice is the shaded side chains on each of the four molecules. So even though many of the molecules that bind the estrogen receptor have very different chemical structures, they all fit in the ligand binding pocket. All the ones that are in use at least have high affinity. And molecules that have these side chains disrupt the active conformation of the ligand binding domain of the estrogen receptor, which targets the AF2 region, which I'll show you in a minute. So this is just a schematic of the estrogen receptor, ER alpha, which is what I'm focusing on. And you can see that it has a DNA binding domain, it has a ligand binding domain, and associated with the ligand binding domain is the so-called activating function 2, which is just a term that indicates that that region interacts with various transcriptional activators and repressors, and that interaction is controlled by whatever ligand is bound there. And then at the other end, at the amino terminus, we have the AF1 region, which is less dependent upon the ligand binding domain in the AF2 region. If we look at an agonist like estradiol, shown on the lower bottom left, then we get the full agonist conformation. And by the way, we define agonist according to the behavior, so estradiol is how we defined agonism, so it's really just an operational term. But when estradiol or DES or other molecules like that are bound, then AF1 and AF2 are fully active, and you get the so-called complete agonist activity of the receptor, depending upon the context. Molecules like 4-hydroxytamoxifen in the bottom middle there are SERMs because they tend to interfere with or disrupt AF2 in the ligand binding domain, but not AF1. And so you still get activity through the AF1 activating domain. And so genes in different tissues and different contexts are selectively responsive to the AF1 and AF2 activity. So the ligands in general mostly control AF2 activity, although a molecule like fulvestrant on the bottom right there, a so-called SERD because it promotes degradation of the receptor, it actually disrupts both AF1 and AF2 activity and also destabilizes the receptor so that it's degraded. So these are representative structures. We're just looking at the ligand binding domain of ER alpha, and we're looking at one monomer, even though the receptor dimerizes. So on the left is the agonist conformation. You'll notice that red helix. That red helix is helix 12. There are 12 helices in the ligand binding domain, and this is the most carboxy-terminal one. When estradiol is bound, for example, it forms an active docking site for coactivator proteins, and that blue helix that you see is just a small region of a coactivator protein that can dock in that active conformation. When a SERM is bound, the side chain that I just talked about disrupts helix 12, but helix 12 has a motif that's similar to the one in the coactivator, and so it can dock in that cleft and disrupt AF2, but not AF1. Molecules like beta-doxifene, they dock the same way that the tamoxifen does, except that they disrupt the region really between helix 11 and 12. So you can see 12 up there in red. I was trying to use the mouse, but it doesn't seem to be working. And so there's some mobility in the structure. which is also what targets it for degradation because it's considered to be misfolded by the ligand by the cell. And the SERD on the right, which could be fulvestrant, for example, is even more effective at disrupting the conformation of the receptor and therefore leading to its degradation. So now I'm going to talk about drugs for treating therapy-resistant ER-positive breast cancers, SERMs, SERDs, and SERN. SERN is a term that was coined by Olema Pharmaceuticals, which refers to complete estrogen receptor antagonists. As far as I know, they're all SERDs, so they're kind of interchangeable as far as I'm concerned. So this just gives you an idea of some of the drugs that are either in use or have clinical potential. I'm going to be talking more about lasofoxifene. I got the arrow finally. But a molecule that's already approved for FDA, it's the only one actually approved recently by the FDA, is elacestrant right here. And then giredestrant is another molecule that's being moved forward by Roche, or Genentech. So I'm going to talk more about these as we go along. And we can stratify these molecules in this sort of line across the top. SERD-like activity, where fulvestrant is over here on the far left, and tamoxifen, which actually stabilizes the estrogen receptors, over here on the far right. Here's raloxifene. I'm going to be talking more about this molecule, lasofoxifene, and you can see there are others that are either in development or have been and have been abandoned, and some of the ones in red are going forward or already approved. Okay, so one of the features of the estrogen receptor that we know about is that in endocrine therapy-resistant ER-positive breast cancers, a significant percentage of them have mutations in the ligand binding domain, as shown here. There are actually some other mutations, but most of them are here. And the two that I'm going to be focusing on and are the most common are Y537S and D538G, and up to 40% in cell-free DNA, actually. So they're really quite common in breast cancers that have become resistant to endocrine therapy, mostly aromatase inhibitors. And I'm going to be and the Y537S mutation, which is the most aggressive mutation, shows up in about 20% of METs and 30% of circulating tumor cells. So some years ago, a graduate student in my lab, Kendall Nuttall, shown right here, was able to solve a structure of the estrogen receptor ligand binding domain with the Y537S mutation. And he happened to be using it at the time mostly because it was convenient and expressed well. We didn't realize back then in the late 1990s that it was going to turn out to be clinically important. But anyhow, what he was able to show is that with or without estradiol, you had the same conformation. So it was stabilizing. And then several years later, Sean Fanning, a postdoc in the lab, was able to solve the D538G structure, and it too shows the active conformation, and this peptide represents a coactivator with or without ligand. So one of the features, by the way, of this stabilization is that it reduces the affinity of the receptor for all ligands, and that's because it stabilizes the active conformation, and so the ligand binding domain can't open up easily to take in another ligand. So the reduction is very significant. It's at least tenfold or more for any ligand, including estradiol, but it reduces the affinity of, say, fulvestrant or tamoxifen so that it moves out of its effective range. So I'm going to talk a little bit about lasofoxifene at this point. It's actually been around a long time. It's a SERM that was developed a number of years ago, and it was tested pretty extensively as a potential osteoporotic inhibitor. 0.5 milligram per day that was given to women reduced the risk of non-vertebral and vertebral fractures, ER-positive breast cancer, heart disease, and stroke. Did increase VTE likelihood, but that's characteristic of all these molecules. It was never approved in the US because of a slight risk of all-cause mortality at a very low dose. And it was approved in Europe for a while, but then Pfizer abandoned it some years later because they didn't feel that it would be competitive in the market they wanted to use it. But nobody considered it really as a potential therapeutic drug for treating breast cancer. So it showed a 79% reduction in breast cancer incidence and 83% in ER-positive breast cancer. It was really the best of all the drugs that was tested at the time, and a meta-analysis showed that it had the highest reduction in risk versus all analyzed drugs, including aromatase inhibitors. It has great pharmacodynamics and pharmacokinetics, and especially the 7-day half-life. So Sean Fanning, who I just mentioned a minute ago in my lab, was able to solve the structure of lasofoxifene bound to the Y537S mutant receptor and compared it to the wild type. And what he noticed is that in magenta here, the side chain of raloxifene actually bumps into this loop between helix 11 right there and helix 12 and disrupts it. But this is for the Y37S mutant, not for the wild type receptor. So we think it actually destabilizes the Y537S receptor a little bit. So the best way that we wanted to test these molecules in preclinical models, there's been plenty of cell-based and in vitro studies with lasofoxifene, was to use a mouse model, the mammary introductal model, in which tumor cells are injected through the nipple into the ducts directly, which is a more favorable environment for these cells and more like what you would find in people. This was really started by Dan Medina a number of years ago, and then Catherine Briskin kind of popularized this technique in models, and we've adopted it, and other people are now too. So when established ER-positive cell lines and from patient tumors or cell models are engrafted into the mammary gland ducts, the tumors are transplantable, predictive, genomically stable. You don't have to supplement the mice with estradiol. It's not necessary. And importantly, these tumors closely mimic the original patient tumor, unlike mammary fat pad xenografts, which acquire basal characteristics very quickly, are not very representative of luminal breast cancer. So in this particular study, we're comparing lasofoxifene against fulvestrant in this mine model, both against wild type. These are MCF7 cells that are either wild type, or they have one copy of Y537S, or they have a copy of D538G. And this just shows the timeline. So what we observed, well, first of all, even the wild type MCF7 cells grow because it's the mine model without estradiol added. And you do see inhibition with lasofoxifene right here, and fulvestrant too, by the way. But if you look at the Y537S, now you see a difference. First of all, these are much more aggressive, and you get considerable primary tumor growth inhibited by lasofoxifene, much less so by fulvestrant. Fulvestrant is more effective in D538G. So then we went to, and then in terms of metastasis, the lasofoxifene really did a good job of preventing metastasis to the liver as well as to the lung and bone. I'm showing you the liver here, whereas fulvestrant did not. So then we did a combination to fit with the fact that CDK4/6 inhibitors are used routinely. And we saw that lasofoxifene was very effective in the Y537S model, which is what we used. Fulvestrant much less so, which is shown right here. And I'm showing you one metastatic site, bone, where again, fulvestrant is really not effective, but lasofoxifene is very effective, and the combination is even more so. So just to summarize this, lasofoxifene is highly effective at inhibiting the growth of this mutant cell line that represents ER-positive metastatic breast cancer. It's substantially more effective than fulvestrant, and the combination is superior to fulvestrant. And fulvestrant did not inhibit metastasis of the Y537S mutant cells. So now I just want to shift briefly to a complete estrogen receptor antagonist, which is this molecule down here, OP-1250, developed by Olema Pharmaceuticals. Here you can see where giredestrant is. There's fulvestrant up here. Lasofoxifene is kind of in between. It's out here where raloxifene, here's lasofoxifene, and then here's 4-hydroxytamoxifene and raloxifene on this curve, on this line. So we've been able, Sean again, was able to solve the structure of OP-1250 with the ligand binding domain. I can't show you the ligand because the structure hasn't been published, but I want to point out that this loop between helix 11 and 12 is completely disrupted by the ligand, and so it really destabilizes the receptor. So it's a complete SERD. Also in the same model that I just described, it's very effective. just like lasofoxifene, and this is primary tumors. And the same on metastasis, it effectively inhibits liver and lung metastasis, whereas Faslodex, which is fulvestrant, is very similar to vehicle. In other words, it doesn't do anything. So I just want to finish with, there's 2 clinical studies that are going on right now, one of them for lasofoxifene. This is data that I'm showing that was presented at ASCO. I'm not involved directly in in the clinical trial at all. But even after up to 2 years, and these are heavily pretreated women who have had a CDK4/6 inhibitor, they've had fulvestrant, in some cases they've had chemotherapy, and then when they're put on this combination with abemaciclib, which is another CDK4/6 inhibitor, many of these patients, 6 of them are still progression-free after approximately 2 years, so that's pretty impressive. And they're now starting a phase 3 trial. And similarly for OP-1250, it's a little bit behind on the timeline, but there is a single-agent trial, and these results were reported recently at ESMO. But they are also seeing a benefit. So both drugs are showing promise in heavily pretreated women with mutant estrogen receptor. So that one of the criteria for being in these trials is having at least 1 or more mutations in the estrogen receptor. Okay, so where are we? So lasofoxifene and OP-1250 are similarly effective in a mice model of Y537S mutant DR metastatic breast cancer. There are other ways to target the receptor. We have SERMs and PROTACs. There are probably others as well. Imperfect correlation between ER stability and efficacy. I think I've showed you that, or at least I hope so. My concern going down the road is that SERDs and SERMs will be less well tolerated in terms of quality of life and side effects. Clinically effective drugs clearly do not need to block AF1 activity or destabilize ER. That's an important point. That also tells us something, by the way. It tells us that we actually don't understand what the true mechanism is for effectiveness in breast cancer, because these drugs are quite different from each other in terms of how they behave on the estrogen receptor, and yet they work. Bioavailability, I think, and ER occupancy is likely important. The balance between agonist and antagonist qualities is going to be important, and then obviously we're trying to treat the whole person. The idea at the end of the day is to be able to move these up. So you always test drugs originally in advanced breast cancer, and then as time goes on, if they work, you want to do it earlier and earlier. So I think lasofoxifene might fit that, and maybe other SERMs too. And so I will just end there and just acknowledge the people that have worked. I've already talked about the key people, but this project involved several people and funding from both Olema and Sermonix. So thank you.
So we'll open it up for questions.
Compliment. Sebastian Anton from University of Calabria. I was wondering if among the different therapeutic options tested, okay, you have verified, ascertained the major inhibitory impact on the most important signaling as that of EGF1 signaling, which is hyperactivated in this mutant cell and is crucially involved in the metastatic event.
Is that a question or a comment? We don't know actually what the pathway is that's most important in the activity of these drugs with the mutant receptor. The mutant receptor is hyperactivated, especially the Y537S, and that comes about, of course, as a result of usually trying to get around aromatase inhibitors, but other molecules as well. But I don't know what the...
That's a suggestion.
Yeah.
Thank you.
I don't know. Other questions? No?
There's a question Related to SERMs versus SERDs, so you'd mentioned that with SERMs like lasofaxifene, there are certain advantages in terms of the side effect profile because it's a SERM. Any disadvantages of a SERM over a SERD in terms of targeting ER?
Disadvantages? You do get hot flashes, so that's one of the disadvantages. But beyond that, I mean, for example, it protects the vagina. I think the reason it was never exploited for a long time as a potential therapeutic was because it was considered to be too estrogen-like. And so except for an effect on hot flashes and a very small effect on VTE, I'm not aware of any other side effects that are a problem. And it doesn't stimulate the uterus, so it's not a problem in the uterus. And it does maintain bone density, so it has the properties that you would like. I think that people would be able to take it long term.
That's great. Thank you so much. We are right on time, so we'll move to the next presentation. Pleasure to introduce Dr. François-Clément Bidard from Institut Curie, Paris, who will be reviewing targeting mutant estrogen receptor using ctDNA.
So, good afternoon, everyone. So it's my pleasure to be here, so thank you for the invitation. So, my disclosures. So the purpose of the talk is to walk you through the, very quickly through the ESR1 mutations, mutation landscape and function. Then we'll touch upon the technical insights related to ESR1 mutation detection. And then we'll mostly dive into data that have been generated through a Padawan study related to the kinetics of ESR1 mutation-driven resistance and how you could act on this resistance that is appearing during a first-line endocrine therapy with aromatase inhibitor. So, very briefly, so ESR1 mutations are activating mutations that will restore the function of ER alpha in the absence of estradiol. So, which means these mutations are a mechanism of resistance to estradiol, to aromatase inhibitor, when given at the metastatic stage. In terms of mutation landscape, as already shown, so we have hotspot in ESR1, so mostly in exon 5 and exon 8, which are on the ligand binding domain. And so on the table, you see that you have, so the frequency is quite well known now and quite stable across studies. These mutations, and the most important thing here is to note that these mutations are detected so after resistance to AI given at stage 4. So in patients with primary ER-negative breast cancer, so the detection rate is 0, or let's say less than 1%. In ER-negative breast cancer, also a 0% detection rate. In patients that are relapsing, we had small studies showing that prior to any treatment in patients with stage 4 disease, prevalence was about 5% or less. And then in patients who had a prior resistance to aromatase inhibitor, we had preliminary reports showing that about 40% of these patients have these mutations that could be detected in the blood. And then this slide is about how we detect ESR1 mutations. So these mutations are detectable by subjecting tumor tissue. If you rebiopsy the patient, so you will be able to detect ESR1 mutation, but it is usually much easier to detect these mutations through ctDNA analysis, which has become, I would say, the gold standard for ESR1 mutation status assessment. And then, so depending on the level of ctDNA that is circulating in the blood, you could apply different techniques. But in most metastatic patients, so the mutations are detected, at 1%, could be even lower, so which means we need very sensitive techniques, such as on the one side, NGS and with UMI, so unique molecular barcode, and also digital PCR. So both of these techniques are advantages and drawbacks. So in very brief, digital PCR is super quick. You don't need bioinformatician. It is cheap, but you will cover only a few hotspot mutations. On the other side, you have the NGS-based detection, so which will allow you to sequence the entire ESR1 gene or part of it. And this is illustrated here in this figure comparing the hotspots that were covered by the ddPCR that we used in PADA1. So this trial we used the ddPCR. So the cost in an academic center in France of one real-time test was less than 100 euro. And here you see the sequence that is sequenced by a Guardians 360 assay, and so the price of Guardians 360 may vary between countries, but it's I think more than several $1,000s. When it comes to ctDNA, I'd just like to remind you that ctDNA detection depends on tumor volume and activity, and ESR1 mutation not detected cannot be called as ESR1 negative. So the patient with ESR1 not detected, it is in fact a mix of ESR1 not detected and ESR1 mutation really absent, so to be kept in mind. So I'm gonna move. Yeah, so what about the kinetics of ESR1 mutant resistance? So we had, as I said, prior results that were obtained in a prospectively collected sample in small cohort studies, but we have also the result of one large interventional clinical trial that was conducted in about 1,000 patients in France. That trial name was PADA1, and it had different steps. First steps, we would call it observational, so patients with endocrine sensitive metastatic breast cancer were treated with AI plus palbociclib, and we were detecting in real time ESR1 mutation in blood, so I call them B ESR1 mutation, at inclusion 1 month and then every 2 months during treatment. So this was step one, was the watch part of it. But then the trial was also interventional, so which means in patients with detected rising ESR1 mutation, so when the mutation was detected throughout the treatment, at any time throughout the treatment, and if the patient had no synchronous disease progression, patients were randomized between a switch to fulvestrant and palbociclib to being maintained under the same treatment, which consisted in AI plus palbociclib. And these patients were also a crossover to fulvestrant palbociclib at time of disease progression. So really, the aim of PADA1 was to interrogate the clinical utility of ESR1 testing together with the actionability of ESR1 mutation. So what about the feasibility? So we had 1,000 patients, and each of these patients underwent serial testing for quite a long time, because the PFS on AI plus palbo is, as you may know, longer than 2 years. So in total, on 2 central platforms, we have done more than, actually it was 13,000 tests that have been done in real time with the multiplex drop-off PCR that was used. So the cheap one, very quick, but it allows us to do massive testing in this sample. So the feasibility in terms of turnaround time was good, and it has been published, and also QC, so post-hoc QC analysis, so quality check versus NGS, and you see that the ddPCR, the mutant allelic fraction, was nicely correlated between ddPCR and NGS. So it was a massive testing effort, and overall 2% of these samples were tested positive for these rising ESR1 mutations, so these mutations that are appearing during treatment and that are the sign of a molecular resistance that is on its way. So what about the result we got in PADA1? First, we'll start with baseline results. So these patients are endocrine, so their tumor are endocrine sensitive, and we knew that prior results suggested a very low detection rate in this patient, and we confirmed this very low detection rate. It was 3.2% in our patient population. We looked at the clinical factor associated with the prevalence of ESR1 mutation at diagnosis, so not later on, but at diagnosis. So, and you see that you had an slight increase in patients with bone mets, postmenopausal women, and prior exposure to AI. But even in this patient, 7.1% is still very low. So clearly, these ESR1 mutations are appearing after AI exposure at metastatic stage and not at relapse. So we looked at the outcome of these 33 patients versus the other, and in terms of median PFS, so these patients with mutant with a ESR1 mutation and who were treated with AI and palbociclib had indeed a shorter time to progression as shown here versus the other patients. But also because we are using the time point at 1 month, we had so the baseline time point, but also after 1 month on treatment, we were able to divide these 33 patients into 2 subgroups. So 2/3 of this subgroup had a cleared ESR1 mutation at 1 month, and 1/3 had a, let's say, persistently detectable ESR1 mutation at 1 month. And if you look at the outcome of these patients, so the patient who cleared this ESR1 mutation had a 24-month median PFS on AI plus palbociclib, so suggesting that yes, ESR1 mutation at baseline is telling you something about the resistance, but if you are able to clear it, and the clearance might be attributed maybe more to the CDK4/6 compound than to the AI, which is supposedly inefficient. So you still have a very, very good PFS. But of course, the one with a persistently detectable ESR1 mutation at baseline had, at 1 month, had a short PFS. So the key message here are BESR1 mutations are rare before first-line AI plus CDK, and we could still have long PFS with AI plus palbociclib in most of BESR1 mutation-positive patients. What about the other time points? So later on during the trial. So first we looked at the incidence of ESR1 mutation, and these are cumulative incidence here that are mutations that are appearing throughout the treatment versus disease progression. And what is very interesting is that at the very beginning of the treatment, so in patients with spontaneous resistance to a treatment, so we detected very few ESR1 mutations, suggesting that these mutations are really selected in tumors that have some kind of sensitivity to the treatment. So the tumors that are spontaneously resistant don't need to acquire an ESR1 mutation. So this is illustrated in numbers. You see that during the first 6 months on AI plus palbociclib, so the appearance of ESR1 mutations, we have been able to detect some of ESR1 positive patients, but definitely after 6 months, ESR1 mutation becomes the most prevalent mechanism of resistance. So I think it's very interesting in terms of development of SERD and in which patient you could test for ESR1 mutation. What about the switch trial results? Remember, these patients, so we followed them, and as soon as they had an ESR1 mutation detected at any time point during that treatment, so rising ESR1 mutation, if they had no synchronous disease, which happened in about 1/3 of our patients, so the 2 other thirds of the patients were randomized between being kept on the same treatment, so that is a blue PFS curve, versus switching to fulvestrant plus palbociclib. And as you see here, so the strategy was successful with a very significant, I think clinically significant impact, and also it was also statistically significant with a doubling of median PFS, and of course no expected toxicity. We are just switching. Patients were on AI plus palbociclib, they were switched to fulvestrant palbociclib, so we are just making a small change in their endocrine therapy. What about the crossovers that was offered to patients here that were kept on the same treatments? They were offered to receive fulvestrant plus palbociclib after disease progression. So in these patients, median PFS was 3.5 months, so which is suggestive that this crossover does not allow to catch up with the early switch. So basically, an early switch could be let's say superior to a late switch based on the actual radiologic tumor progression. What about the PFS2? So PFS2 defined as it's a classical definition, so from randomization to the second tumor progression. So data reported at ASCO, and so we have still a clear advantage in favor of the early switch, so suggesting that these patients really gain something in terms of PFS1 and PFS2 compared to patients who remain on treatments. And so if we move to last kind of result with PADA1 is, so we looked at also the kinetics of patients that were randomized, so patients were ESR1 mutation positive, rising ctDNA, so they had no concomitant disease progressions. These were allocated to either AI plus PAL, so unchanged treatment, versus fulvestrant plus palbociclib, And you see here on the light green patient that had a cleared ctDNA, so no ESR1 mutation detected at 2 months after randomization and treatment switch are being kept under the same treatment. So clearly, you see here that at the molecular level, the efficacy of the switch. And of course, the status at 2 months was also had a very significant impact on the patient outcome. So this is not surprising, but again, it shows the benefit of at the molecular level of the switch. So what are the potential benefits of this strategy that was investigated in PADA1? So we are, in fact, maximizing the SERD efficacy. We are, patients are being kept on the SERD, for a longer time period. So I think it's quite interesting. And, apparently, the time from randomization with fulvestrant palbociclib could be superior to AI followed by fulvestrant. What is the reason of that? It could be that it's interesting to target resistant mutation as soon as they become detectable. And so it could be related to a smaller amount of resistant cell at time of the molecular detection in blood versus at time of radiological detection. And this concept has been first observed in PADA1, but has been kind of supported also on a quite similar trials, but at smaller size that was run by EORTC on non-small cell lung cancer patient with EGFR mutation. And so I think it's really resonate again with the idea of keeping patient on CDK4/6 inhibitor after having a disease progression. As we had several trials, but PADA1 could also allow you such strategy. So I think that it could be a new path to personalized care. So we are, let's say, targeting the mutation with a good drug as soon as it is appeared. And this concept, the concept of PADA1, has been taken over by industry here. It's AstraZeneca, which has launched a global registrational phase 3 trial for the oral SERD, camizestrant. So it is the same design basically as PADA1. There are small differences, but I have no time to walk through them. But key advantage of SERENA-6 is that it is not using fulvestrant as in PADA1, but it is using camizestrant. And we know in a head-to-head comparison, camizestrant was much more active than fulvestrant on these ESR1 mutations, so we expect this trial to be a success. The trial is still enrolling currently, and so we are still waiting for the result. But it is a registrational trial as agreed on by FDA, EMA, and the Japanese regulatory bodies. So I think it will be the first trial really that could register a drug based on these sequential monitoring of resistance mutation. In conclusion, this is my last slide. So how to tackle these ESR1 mutations. So we have 3 strategies, and I think that Erika will touch upon these different trials after my talk. One is trying to catch up when these mutations have already driven disease progression. So these are the first-line trial we are conducting and that have been conducted. So these names are Emerald, Ember3, Accelera, Veritac2. We could also try to target this mutation as soon as they become detectable. So that was the purpose of PADA1. And again, this is pursued now in SERENA-6. And lastly, what about preventing the appearance of these ESR1 mutations? So 40% of patients will develop an ESR1 mutation. So this patient population, and it could be also a broader benefit than these 40% of patients. So we could have a benefit by using these new oral SERDs, which are more potent than fulvestrant, in the context of upfront first-line therapy to prevent these ESR1 mutant-driven resistance. And these are the first-line trials that Erika will show you, Persevera, SERENA-4, Veritac. We don't have yet the result of this trial, but they are also very promising. Thank you very much for your attention.
Thank you so much. We'll open it up for questions. Microphone.
Hello. Hannah Tukachinsky from Foundation Medicine. Wonderful presentation, beautiful presentation of the work. I was wondering about the ER clearance. Did you see an association with the starting ER amount, either in terms of just raw VAF or clonal tumor fraction ratio, and also whether you looked into specific mutations and whether they were more likely to clear than others?
Sure. First, this is a very specific setting. So it's not the setting where you used to see these patients have no disease progression. So we are targeting ESR1 as soon as they become detectable. So as soon as the mutation is above the detection level, so then we'll target it. So which means all patients and most patients had ESR1 mutation when they were randomized at super low allelic frequency. Because they were tested negative before and they become positive. So we don't have patients with 10% MAF and so on. This kind of level we are used to see in patients with overt disease progression. So it's difficult to answer your question about association with MAF because these MAF are super low. So no answer on that. About the association of, between the mutation type, so namely the Y537S mutation versus the other, that's what we tested, and it appeared that it had no specific impact on the patient outcome in both arms, so in the AI and fulvestrant. So that's what we got. And in terms of clonality, so again, we are detecting very small fractions. So our ability to detect a subclonal event, that would be 2 mutations, and one would be at a higher level, and the second would have a lower level, because we are just detecting the first mutation that is popping up. So we did detect some subclonal or polyclonal mutation, but the frequency of this polyclonal mutation were, I don't remember honestly the rate, but it's something like 10 or 20%. So it's
Hi. Microphone 2.
Nick Durutoglu from Greece. Thank you for your presentation, very informative. I would like to ask your thoughts about what happens to the patients who do not respond to ESR1 inhibition, where there may be very short-lived response, or in the cohort you showed what happens when they stopped responding after the PFS was over. Do we have any information as to the mechanisms of resistance to elacestrant, or how does that evolve?
Well, so I'm not sure that the trial will be able to answer the question related to patient outcome and length of response, because it's how you define response. These patients have no disease progression, so you don't expect a further response of their disease once they are switched. So let's say the response part of your question, I'm not sure I can answer. About what happens when this patient become resistant. That's very important. We don't know the mechanism of resistance to fulvestrant. We don't know the mechanism of resistance to SERD. There has been a recent paper pointing out at a mutation in ESR1, so the 404 codon. And so we looked in our database in PADA1, and we found it in 1 or 2 patients. So it is there, but apparently not the major could be not the major mechanism of resistance. But what we did observe in PADA1 is that at time of progression, so when patients were allocated to either AI plus PAL or fulvestrant plus palbociclib, the group of patients treated with fulvestrant palbociclib had less ESR1 mutation detected at time of tumor progression, suggesting that this tumor may have found something else than ESR1 to progress on fulvestrant plus palbociclib.
Thank you.
So in the interest of time, and Dr. Bidard also has a flight to catch, we'll move to the third presentation, Future of Oral SERDs by Dr. Erika Hamilton from Sarah Cannon Research Institute, Nashville.
Thank you. So the disadvantage of going last is you're going to see a few slides that look similar to what Dr. Greene and Dr. Bidard presented. Before he's fully out of the room, that was the best thorough explanation of PADA1 I've ever heard, so that was fantastic. Okay, so let's dive into the future of oral SERDs. These are my disclosures to say that we do a lot of clinical research. I take no personal funds from pharma. So mechanism of action, and I think it's important to get back to this. This is why we see different activity with these agents, is because they truly do act in different ways. So normally estrogen binds the estrogen receptor that gets taken into the nucleus, acts at transcription and downstream processing. With aromatase inhibitors, we're really counting on the aromatase inhibitors preventing the conversion of normal body steroids into estrogen after menopause. And so there is not estrogen to bind to the estrogen receptor, and therefore you can't have the downstream signaling. For the SERMs, this really is a estrogen mimicking agent, so it binds the estrogen receptor, and in some tissues this has agonistic activity, and in some tissues it's antagonistic, so it really causes conformational changes there. And in terms of SERDs, again, this is a molecule that binds the estrogen receptor, but really flags this for degradation and ultimately ER turnover within the cell. So what are the advantages of the new oral SERDs? Clearly that it's oral. Our patients don't like 2 shots every month from fulvestrant. We also have issues with PK with the formulation of fulvestrant. We have higher potency, and as we've seen, we have activity post-CDK4/6, where we tend to be struggling with fulvestrant with a median progression-free survival of less than 2 months across multiple trials. So this is a slide you've seen with a slightly different twist. And I think this just goes to show that, despite the fact that we kind of conceptually want to think about these new, endocrine agents in all one class, they really are different. And so you can see all the way over on the left, highlighted in yellow, is fulvestrant. And then we see most of our SERDs sitting in this bucket here, where they clearly have more SERD activity and less SERM activity, except for elacestrant, which is actually more of a SERM than it is a SERD. And then you see compounds like vepdegestrant over here on SERD, and other compounds that we brought up today, lasofoxifene, H3B, our SERCA, which hasn't been discussed, as well as tamoxifen and trimethoprim. So I am not going to go through this table, and I bet you're glad I'm not, but this really is just to show that there has been a lot of activity in phase 1 with these oral SERDs across multiple compounds, and also to just highlight the heterogeneity in this trial. It is really hard to compare apples to apples in these trials because A, it's a small number of patients, and B, they really differ in their clinical characteristics. You can see median lines of therapy from 1 all the way up to 4 in these trials. And in fact, you can see prior fulvestrant ranging from 20 all the way up to 65%. And as you imagine with these different scenarios, we're going to see different activity with these. So what about in combination with CDK4/6? This really is quite exciting data. We've seen multiple combinations and actually saw more data this year here at this meeting in terms of combinations. We do tend to get a little bit higher response rates when we combine with a CDK4/6 inhibitor. Typically with single agent endocrine therapy in the metastatic setting, we don't anticipate to see a high response. These aren't tumors that just melt away. They're a little bit slower growing, slower dividing, similar to the way we often don't see pathologic complete responses to neoadjuvant chemotherapy in ER-positive breast cancer, but it's more common in triple-negative and HER2. So let's dive into some of the trial data. This was the Emerald trial. These patients had progressed after 1 or 2 lines of endocrine therapy, and everyone had already seen a CDK4/6 inhibitor. You see about a little less than half of our patients had had 2 prior lines of endocrine therapy. The minority, only about 1 in 5 patients had seen chemotherapy, and ESR1 mutations were right under the 50% mark. Patients were randomized to receive elacestrant daily or investigator's choice of standard endocrine therapy single agent, and the most common here was fulvestrant. So on the left, we can see progression-free survival in terms of the intention to treat all-comer population, and this was statistically significant, but I think we were a little bit disappointed with the magnitude of benefit, really improving progression-free survival by a month from 1.9 up to 2.8 months. And if we look over on the right, we were able to enrich for a patient population that got greater benefit by picking those patients that had ESR1 mutations, and now our progression-free survival benefit was essentially doubled, 1.9 to 3.8 months. Now, when we look at progression-free survival by duration of CDK4/6 inhibitor, this gets even a little bit more interesting. So on the top, going across horizontally, we have all patients. On the bottom, we have those patients that have ESR1 mutations, and then our columns are at least 6 months on prior CDK, 12 months on prior CDK, or 18 months on prior CDK. And you can really see a cutoff for those patients that had been on CDK for at least 12 months. And then if you look at kind of this ideal scenario in the bottom right, where a patient patient has an ESR1 mutation and they had been on their CDK for at least 18 months, you see elacestrant giving us a progression-free survival of 8.5 months, which I think we would all say is definitely clinically significant. I think the challenge in this setting is that we don't have a great assay to tell us who is still endocrine sensitive and who isn't. It's not as simple as still being ERPR positive. I do not think it is as simple as just having an ESR1 mutation, but really a lot of factors are at play, and we haven't quite figured out who these patients are that will benefit and who are the ones that won't. So we also had negative clinical trials. This was AMERA-3. It was a phase 2 of amcinestrant versus endocrine therapy, a relatively similar population, less than or equal to 2 prior lines of endocrine therapy for advanced breast cancer. You can see that it was a smaller study, only about 290 patients, prior fulvestrant in about 10% of patients, CDK4/6 in 80% of patients, but not everyone. And again, this was amcinestrant versus endocrine of treatment of physician's choice. What we saw in terms of progression-free survival in the top right was really no difference in the intention to treat population. If we did select out those that had ESR1 mutations, we did start to see the curve separating a little bit, but it still was not statistically significant. And the thing that really stands out to me on these curves is that you have about half of patients just progressing at the first scan, no matter what arm that they're given. Amcinestrant is no longer in clinical development. So this was Accelera. This was a phase 2 trial of giredestrant in ER-positive metastatic disease. Again, a relatively similar design, also a little bit of a smaller trial as well. 1 to 2 prior lines of systemic therapy and up to 1 prior chemotherapy. CDK4/6 was less frequent here, only 42% of patients, and we did see ESR1 mutations in about 40% of patients. You see a very similar story to the previous slide, really no benefit and no perceivable difference in the curves in the intention to treat population, but among those 40% of patients that had an ESR1 mutation, we can start to see this curve separate a little bit, 3.5 versus 5.3 months, so almost that 2 month, but we didn't have the power in this subset for this to be significant. So this is our other trial with positive randomized data with an oral SERD. This is SERENA-2 with camizestrant. These patients had not seen prior fulvestrant or an oral SERD. They'd had no more than 1 prior line of endocrine therapy in the metastatic setting and no more than 1 chemotherapy. And you see they looked at 2 different doses of camizestrant, both 75 milligrams as well as 150 milligrams, and a very clean design just against fulvestrant. You can see that prior CDK was around half, about 51% of patients, and the majority of patients did have visceral disease. We saw ESR1 mutations in 30 to 40% of these patients. What we saw in terms of progression-free survival, our 2 camizestrant curves are in blue here, and red is fulvestrant, and so fulvestrant gave us a progression-free survival of 3.7 months, and you ask yourself, well, why was that a little bit better than we expected? Remember again that over essentially half of these patients had not seen CDK, so this was the old activity of fulvestrant. And then for both of our camizestrant arms, we had progression-free survival in the 7-month range. Over on the right, you just see this highlighted among all comers or those with ESR1 mutations, but you really see a benefit with camizestrant regardless of ESR1 compared to fulvestrant. So what about the side effect profile? This is obviously very important for our patients. Oral SERDs can have mild GI toxicity, a little bit of nausea, a little bit of diarrhea. I think that this is actually different among compounds in the class, but it's very hard to tease out in a phase 1 population. We also have select SERDs that can have bradycardia or this odd visual phenomenon that we're classifying as photopsia, which doesn't impair reading or driving or anything like that. It's just when there is a change in ambient light, you get a little bit of waffling of your vision temporarily, 30 seconds, a minute maybe. And so what does that mean? It means that when they turn the lights off on their nightstand or when they walk into the bathroom in the first morning and flip their light switch on, they have a little bit of transient waffling of their vision, and then it goes away the rest of the day. In terms of aromatase inhibitors, these really can be quite challenging for our patients, especially when we're asking them to take these drugs for 5 years, 7 years, 8 years, or even 10 years, including arthralgias, sexual side effects, osteoporosis risk, hot flashes, and fulvestrant obviously has the side effect of injection site pain as well. So, these oral SERDs are not equal. I think we've highlighted this between the SERD-SERM activity. Certainly, Dr. Greene did an excellent job really talking about the structure and how, from a 3D perspective, that these molecules that have a different shape really can interact differently. So I think eventually we may get smart enough to realize that one compound may be better for a certain patient with a certain mutational profile, and a different compound may be better for a different patient. So again, we're left with two negative oral SERD trials, Accelera and Amira. Possible explanations, certainly they were designed different. They were smaller trials. They did have a more endocrine-resistant population, and there may be differential efficacy between the oral SERDs. Emerald did meet its primary endpoint and ultimately was FDA approved for those patients that have ESR1 mutations. And SERENA-2 has also shown a benefit over fulvestrant, including those patients that have ESR1 mutations as well, although not currently FDA approved. This is undergoing further trials. So what's on the horizon? Where are we going from here? And in fact, these compounds are in a number of trials really across a number of settings. We have SERENA-4, which is camizestrant with palbociclib as first line. I think that, first line is a very attractive place because we're not going to have to deal with as much endocrine resistance in first line. The liability in this setting is that we're combining with CDK4/6. And so how much is CDK4/6 going to drive the prognosis of how our patients do versus the endocrine backbone? This is a relatively straightforward trial, 1-to-1, camizestrant with palbociclib and a anastrozole placebo, or a anastrozole palbociclib with camizestrant placebo. We also have a similar trial, EMBER-3, but this is actually a first and second line trial, and it's intended for patients that have already been on a aromatase inhibitor. And so you see three arms here. The vast majority of patients in the United States, for example, or where CDK will be approved, probably will have already had a CDK with their aromatase inhibitor, but they do allow patients that relapsed quickly as well. And it's imlunestrant versus fulvestrant or exemestane on the standard of care arm, and then also has this additional arm, imlunestrant with abemaciclib, asking the question, at least in a proportion of patients, about CDK after CDK. So this is PADA-1, and you certainly heard this explained much better than I'm going to do, but really setting the stage for the ongoing clinical trials, asking this question of should we be switching patients' treatment based on ESR1 mutations? So again, these patients were all on aromatase inhibitor with palbociclib, and if they had emergence of an ESR1 mutation, they were randomized to either stay on their AI and palbociclib or switch to fulvestrant and palbociclib. And then you also see this PFS2, how this is designed with the crossover to fulvestrant for those patients that are on AI. And whether we look at the left, PFS from randomization, certainly looking better for those patients that switch, and this shouldn't be surprising. And PFS2 looking from randomization looks better as well. So OS data certainly is awaited. I think the big question for many of us is certainly we have the technical capability of determining whether patients have emerging ESR1 mutations. Certainly we can switch their therapy, but the question is, should we? Are we going to improve outcome? Are people going to live longer? Are they going to end up with less burden of disease and feel better somehow? Or are we just eating through our therapies quicker and ultimately almost wasting these therapies without evidence of actual progression? So this is going to help us hopefully answer this. This is SERENA-6. It is with camizestrant. It is similarly designed for patients that are on CDK4/6 with aromatase inhibitor with or without LHRH agonist. It is going to be a large clinical trial, 2,000 patients coming into the detection phase. They'll be monitored every 2 to 3 cycles for ESR1 mutations. If they remain negative for ESR1, they continue on their therapy. If they turn positive for an ESR1 mutation, they move over to the right side of the screen where they enter the randomized treatment phase with a goal of 300 patients. Again, this will be looking at remaining on AI with CDK4/6 and placebo for SERD, or switching to SERD with CDK and placebo for the aromatase inhibitor. So what about early breast cancer, and why are we being so aggressive about putting these drugs into early breast cancer so soon? So this was Cupra. It was a phase 2 neoadjuvant trial looking at giredestrant versus anastrozole. These trials really serve a couple purposes for us. One, it's a proof of concept that yes, these drugs are better than aromatase inhibitors. And it also helps us make sure that we have the right dose. The liability with these endocrine agents always are that these aren't drugs that we're going to hit an MTD. We certainly made a mistake with fulvestrant for quite a bit of time, and we'd probably all be using fulvestrant in the adjuvant setting if we had gotten the dose right at 500 milligrams and not run out of patent life. And so this also really helps us make sure that we have the right dose of these drugs going into larger trials. These patients had ER-positive disease. They had at least T1C tumors, baseline tumor tissue, and had to have Ki-67 scores of at least 5%. They went on to receive essentially a window of giredestrant versus anastrozole, and then went on to a phase where they received the drug with palbociclib before surgery. You can see on the left the single agent activity, anastrozole versus giredestrant, with giredestrant dropping our Ki-67 just a little bit more, and a similar story even with combination with palbociclib, also a little bit more improvement with palbociclib and giredestrant. Also consistent Ki-67 suppression was observed. You can see this kind of 71% versus 83% in favor of giredestrant. And EMBER-2 was also a window of opportunity, relatively similar, looking at several different doses of imlunestrant in a 14-day pre-surgical window. And we also saw a quite significant drop in both ER and Ki-67. You can see the relative reduction in ER transcription activity at week 2. And again, remember that these are only 2 weeks of a drug that we know takes some time to reach to steady state. So what about other agents? This is our PROTAC, or proteolysis targeting chimera. We have our little rainbow molecule that binds our green blob, which is our target protein, the estrogen receptor here. This recruits in E3 ligase and ultimately ubiquinates the molecule. Proteasome comes in and gobbles it up and spits it out. So this was our phase 1 data from ARV-471, the PROTAC. Very well tolerated, had no dose-limiting toxicities. Clinical benefit rate was about 40%. And you can see over on the right, although it's very small, you'll have to pull this up later, that it's annotated who had received prior fulvestrant chemotherapy. And a couple of patients had already seen investigational SERD and did quite well on PROTAC, which was very reassuring. We presented this data yesterday in one of the spotlight sections. This is vepdegestrant in combination with palbociclib. These patients, for the most part, had already seen CDK4/6, very high rates of this, and in fact, the vast majority of them had already progressed on palbociclib, 75%, yet we saw a clinical benefit rate of 63%, a duration of response in those patients of 10.2 months, and a progression-free survival of 11 months post-CDK that was actually identical whether patients had ESR1 wild type or mutations, which I think was very encouraging. This is the VERITAC trial. Dr. Sarah Hurvitz presented this. This was single agent activity with vepdegestrant, and you can see that at both 200 milligrams, which is where we're going to be moving forward with this, that we have a clinical benefit rate of about 40%. We can boost this up if we pick patients that are ESR1 mutated, and progression-free survival we can also boost a little bit by picking patients that have ESR1 mutations as well. This is the phase 3 VERITAC trial, and this will be ARV-471 straight up against fulvestrant in a so-called second-line setting where patients have already seen CDK4/6 inhibitor. And then finally, VERITAC-3, which will be vepdegestrant in combination with palbociclib in the first-line setting against letrozole and palbociclib. We actually determined that we had a little bit more neutropenia with the combination of vepdegestrant and palbociclib, and that's because we have higher palbociclib exposure, about 50% higher, and so we're actually going to go in at a little bit lower dose to make that palbociclib dosing what we would expect and not higher. This is the CERAN. This was already talked about a little bit. It's essentially a complete estrogen receptor antagonist and a degrader, so it not only turns off activating function 1, but also 2. And you can see a similar activity with the same number that we keep repeating in a phase 1 trial of a clinical benefit rate of about 40%. Again, this is a heavily pretreated population with almost half of patients having at least 3 prior therapies. And again, we see activity in wild type as well as those that have ESR1 mutations. We do see progression-free survival about a month longer among those patients that have ESR1 mutations. And so this is where we stand, and it is a busy field. So you can see on the top, we have the metastatic setting, first line in combination with CDK, we have switch strategies, and we have second line post-CDK. And on the bottom, we have not only neoadjuvant studies, but adjuvant settings, both in an upfront flavor, as well as Cambria-1, which will be testing a switch strategy after 2 to 5 years of adjuvant endocrine therapy that is not biomarker-driven. So this is my attempt at a crystal ball. I think SERDs really do appear to need endocrine-sensitive disease, and unfortunately, we are not quite smart enough of predicting this. I think that this first potential is for this to be earlier, either adjuvant setting or first line. I think Protacs and Serans are certainly maybe a little bit more effective in pretreated disease. I think they certainly could go beyond this, but I anticipate that they'll find their first place and first approval in perhaps second line, where endocrine resistance is more important for the SERDs. So again, oral SERDs are active as monotherapy. They are more pronounced in terms of activity with ESR1 mutations. All SERDs are not equivalent in function or response. They have different side effects. We should know this. Oral SERDs certainly have demonstrated the ability to suppress Ki67 in window of opportunity trials. I feel very confident putting them in the adjuvant setting, and I'm excited about this. Novel ER degraders like Protacs may offer some advantages over oral SERDs in certain settings. They may have a little bit more activity in patients that are endocrine resistant. They may have a little bit of a different side effect profile. And the current clinical challenge, far and away for me, is to identify the patients that will respond and those that won't to these endocrine agents, and we really need an endocrine sensitivity assay. Thank you.
Excellent. We're slightly over time for one quick question. I'll take a question that was posed online, which is, as we have these multiple agents available, and if they get approved, how are we going to select the different ER agents and sequence them?
Let's see if this is on. No, of course it's not. Is that one right? I think that's a really interesting and difficult question. The first thing is that I think we have room for more than one. Before the CDK4/6 inhibitors, we all remember that we sequenced endocrine therapies. If patients were still responding, we picked a different one and we did it again. So I really do think that we'll end up with a novel endocrine agent in the adjuvant setting. I think we'll end up using them in first lines and perhaps even second lines. And so I really do want to highlight that these compounds are different across the classes, and I think we will be using multiple of them.
Thank you so much. We'll close the session. Thank you.